Hi, today we are going to discuss a very important topic, that is neonatal jaundice and kernicterus. Okay, firstly, let's quickly see the previous year questions that have been asked from this topic. So, what are the causes of unconjugated hyperbilirubinemia has been asked. Physiological jaundice, Rh negative mother and a Rh positive baby. What will happen? Okay. Then they've asked about bilirubin encephalopathy. Okay. Then they've asked about kernicterus. Okay. Again, one more question on Rh negative mother and Rh positive baby. Okay. Then they've asked about um, laboratory investigation of a hemolytic jaundice and what will be the treatment, phototherapy, exchange transfusion. All these questions have been asked. Okay. We'll discuss all these questions in these slides, and again we'll come back to them and see how to solve these questions. Okay. So firstly, let's start with what is neonatal jaundice. So jaundice is basically yellowish discoloration of skin and sclera. In case of neonates, the yellowish discoloration appears if it is more than 5 milligram per deciliter. If the bilirubin level is more than 5 milligram per deciliter, the yellowish discoloration appears on the face. Okay, so this is jaundice, and in adults it is 2 milligram per deciliter, but in neonates it is more than 5 milligram per deciliter. Now there are two types of bilirubin. One is conjugated bilirubin, the other one is unconjugated bilirubin. Okay, if you see this briefly, see initially you have heme. Okay, so we have RBCs. These RBCs, they will break down and they will release something called as heme. Now heme is converted by an enzyme which is heme oxygenase into biliverdin. Okay, and then biliverdin is converted into bilirubin by an enzyme biliverdin reductase. Okay, now this bilirubin which is formed is unconjugated bilirubin. Okay, this is unconjugated because it has not been conjugated by any enzyme. So this is unconjugated bilirubin. Okay, and this is also unbound. Okay, if it is bound to albumin, it binds to albumin and forms the bound part of bilirubin. Now this bilirubin will go into the liver, and in liver there is one enzyme which is known as UDP glucuronil transferase, or also known as UGT. UDP glucuronil transferase, also known as UGT, and this enzyme is responsible for conjugation of bilirubin. Okay, so this unconjugated bilirubin, when this enzyme acts on it, forms conjugated bilirubin. Okay, now what is the difference between this unconjugated bilirubin and this conjugated bilirubin? Unconjugated bilirubin is also called as indirect bilirubin, and this is fat soluble. Okay, it is fat soluble, so it is not water soluble, and this form of bilirubin is not excreted in our urine. Okay, but what is the property of unconjugated bilirubin is that it can cross blood-brain barrier. So which type of bilirubin causes kernicterus or bilirubin encephalopathy? It is unconjugated bilirubin. So unconjugated bilirubin can cross blood-brain barrier and it can cause kernicterus, it can cause bilirubin encephalopathy. On the other hand, conjugated bilirubin is also called as direct bilirubin. Okay, this is just another name. Okay, this is called as indirect bilirubin, this is called as direct bilirubin. This is water soluble. Okay, because it is water soluble, it can be excreted in urine. Okay, so it is in case of conjugated bilirubin, we see high colored urine. We see very high colored urine, but clay colored stools. Okay, so that is about two types of bilirubin: conjugated bilirubin, unconjugated bilirubin. Unconjugated bilirubin is converted to conjugated bilirubin by the action of enzyme UDP glucuronil transferase, or UGT. This takes place in liver. Okay. Now, what are the causes of hyperbilirubinemia? So, causes of hyperbilirubinemia can be divided into two: unconjugated and conjugated. Okay. So, this is a previous year question. What are the causes of unconjugated hyperbilirubinemia? Okay. So, this can be again divided into hemolytic causes and non-hemolytic causes. Hemolytic causes, very easy. Hemolytic anemias. Firstly, you can talk about hemolytic anemias. What are the hemolytic anemias you know? Hereditary spherocytosis, right? Hereditary spherocytosis. Other is thalassemia. Okay. So these are hemolytic anemias. Then what else? RH and ABO incompatibility. This we'll cover in detail. Okay. When there is a RH negative mother and a RH positive baby, what happens is there is RH incompatibility. Okay. And hemolytic disease of newborn, this we'll see. Then sepsis and DIC also cause hemolytic anemia. Polycythemia. Why polycythemia? Because there are more RBCs. There will be more RBC breakdown, more heme. More heme means there is more biliverdin, there is more bilirubin, and there is more unconjugated bilirubin. Okay. The other thing is cephalhematoma, where due to birth trauma, there is extravasated blood which accumulates in the skull sutures. Okay. And this extravasated blood, when this breaks down, also causes unconjugated hyperbilirubinemia. Then we have non-hemolytic causes, right? Like Crigler-Najjar syndrome. Okay. We have Crigler-Najjar syndrome. We have Gilbert syndrome. These syndromes you don't have to know in detail for UPSC medical science, right? You just have to know that these are syndromes which cause unconjugated hyperbilirubinemia. Okay. And you have breast milk jaundice. So breast milk jaundice we will be studying in detail. Okay. Then conjugated hyperbilirubinemia causes. So conjugated hyperbilirubinemia can be divided into hepatic and post-hepatic. Hepatic causes and post-hepatic causes. Hepatic causes are neonatal hepatitis, torch infections, right? Toxoplasma, rubella, CMV, right? IEM is inborn error of metabolism. Inborn errors of metabolism. Like what? Like galactosemia, right? Like galactosemia. So this also causes conjugated hyperbilirubinemia. Then you have post-hepatic causes like extrahepatic biliary atresia, EHBA or biliary atresia, extrahepatic biliary atresia. This is also a cause of conjugated hyperbilirubinemia. And you have choledochal cyst, which you must have studied in surgery, Todani classification, right? So choledochal cyst is also a cause of conjugated hyperbilirubinemia. Okay, and if you study for PG, then they say Dubin-Johnson and Rotor syndrome. Doctor is conjugated, right? Doctors are conjugated. So this is the mnemonic DR, Dubin-Johnson and Rotors. This is conjugated hyperbilirubinemia. These are causes of conjugated hyperbilirubinemia. What is it? Dubin-Johnson syndrome and Rotor syndrome. These are causes of conjugated hyperbilirubinemia. On the other hand, Crigler-Najjar and Gilbert. These are causes of unconjugated hyperbilirubinemia. So we have studied the causes. Now, how jaundice develops in newborns, this we have studied, right? So what happens basically is, normally heme is converted to biliverdin is converted to bilirubin. This bilirubin is processed in liver, right? Which and made water soluble. How? By conjugation of the enzyme UGT, UDP glucuronidase transferase. After conjugation, it is made water soluble, and then this soluble part will leave the body, right? And it gets excreted. But what happens if the baby has, why do newborn babies have jaundice? Because they have immature liver. Okay. The liver is immature, so the enzyme UGT or UDP glucuronidase transferase is also immature. Now, when this enzyme is immature, proper conjugation does not take place. Because the liver is not yet mature, it will process the bilirubin slowly. So now less conjugation will take place and there will be more unconjugated part of bilirubin. Okay. So less conjugation is taking place. The unconjugated fraction of bilirubin will increase and therefore it will cause unconjugated hyperbilirubinemia. So usually in neonates, what we see is unconjugated hyperbilirubinemia because of immaturity. Okay. Because of the immaturity of enzymes, immaturity of liver. Okay. So therefore, jaundice will be more common in preterm neonates, right? In preterm neonates, there is high propensity of jaundice. Okay. Now let's see the classification of jaundice: physiological jaundice and pathological jaundice. Okay. So physiological jaundice will appear after 2 or 3 things that you have to remember is this will appear after 24 hours. Okay. This will appear after 24 hours and this will resolve within 2 weeks. Okay. It will appear after 24 hours and it will resolve in 2 weeks. Okay. So it will appear after 24 hours and it will resolve in 2 weeks or within 14 days. Okay. Now what happens is that after 24 hours, the bilirubin will start rising. It will reach a peak on 4th or 5th day in term or 7th day in preterm, and then it will start falling down. And by 2nd week in term neonates and 3rd week in preterm, usually it falls down to the normal level. Okay, so this is about physiological jaundice, and always the bilirubin level will be less than 15 milligram per deciliter. Okay, so the bilirubin level will never be more than 15 in physiological jaundice. It will always be less than 15 milligram per deciliter. Okay, so it will appear after 24 hours. It will resolve within 14 days or 2 weeks, and the bilirubin level will be less than 15 milligram per deciliter, and it will not require any treatment, right? You just have to continue breastfeeding. It will disappear on its own. Okay. On the other hand, pathological jaundice will appear within 24 hours. So it will appear within first 24 hours of age, and it will persist even after 14 days. So these are two points that you have to remember: within 24 hours, after 14 days. So these two things are just contrary to physiological jaundice. This we remember now, right? Within 24 hours it will appear. After 14 days of life it will persist. Other thing is, what is the rate of increase, right? So serum bilirubin will increase more than 5 milligram per deciliter per day. So the rate of increase will be high. Okay, every day 5 milligram per deciliter is increasing, and serum bilirubin will be more than, there we studied it is less than 15 milligram per deciliter. Here it can be more than 15 milligram per deciliter. Stool is clay colored or white colored, and urine is staining the clothes yellow. That means this indicates that it is conjugated hyperbilirubinemia. And anytime there is a conjugated hyperbilirubinemia, it will always be pathological. Whether it is appearing after 24 hours of age, anything else does not matter. If it is conjugated hyperbilirubinemia, it is pathological. Okay, physiological jaundice is always unconjugated hyperbilirubinemia. On the other hand, pathological can be both conjugated or unconjugated. Okay, so if the direct bilirubin level is more than 2 milligram per deciliter, if the direct bilirubin level is more than 2 milligram per deciliter, that means it is conjugated hyperbilirubinemia, and conjugated hyperbilirubinemia is always pathological jaundice. Okay, so far so clear. Let's revise this physiological and pathological jaundice once, because it's important. Physiological jaundice will appear after 24 hours. It will resolve within 14 days of life, right? And the rate of increase of bilirubin will not be that high, right? What else? Maximum intensity by 4 to 5th day, then it will start falling down. Serum levels will always be less than 15 milligram per deciliter, and it will disappear without any treatment. On the other hand, if you talk about pathological jaundice, then it will appear within 24 hours of age, right? It will persist even beyond 14 days of life. It can be conjugated also. So stool, if they are clay colored, if the diapers are stained, right, that is by urine. Urine will stain the diaper. Urine staining the clothes yellow. That means it is conjugated hyperbilirubinemia. Okay, and direct bilirubin is more than 2. Rate of increase is more than 5 milligram per deciliter per day, or bilirubin level is more than 15. Then it is pathological jaundice. Okay. Now let's see the predisposing factors of physiological jaundice. One thing I talked to you about was prematurity, right? Prematurity is a predisposing factor for jaundice. Prematurity, why? Because there is immature liver, there are immature enzymes. If there are immature enzymes, so proper conjugation will not take place, and the unconjugated fraction will increase, causing unconjugated hyperbilirubinemia. Okay. Then delayed feeding is another predisposing factor. Delayed feeding or inadequate feeding, these things cause weight loss, dehydration in the newborn. Okay, so dehydration and weight loss, can cause jaundice. Okay, birth trauma or cephalhematoma we studied, this can cause unconjugated hyperbilirubinemia, right? And infants of diabetic mother are also predisposed to jaundice. So prematurity, delayed feeding or inadequate breastfeeding, proper positioning, proper attachment is not there, right? So breastfeeding has to be ensured. And excessive weight loss or dehydration is there. That means the frequency of breastfeeding is not proper, or there is birth trauma, right? History of birth trauma. All of these are predisposing factors for physiological jaundice. Now there are two types here: breastfeeding jaundice and breast milk jaundice. This is given in Ghai, and this is asked sometimes. Okay, breastfeeding jaundice has been asked, and breast milk jaundice has also been asked. Okay. if I have to tell you in one line what is breastfeeding jaundice, this is because of inadequate breastfeeding. ठीक है, cause is inadequate breastfeeding. ठीक से breastfeed नहीं कराया, that will cause breastfeeding jaundice. Inadequate breastfeeding will cause breastfeeding jaundice. So this part is clear. So cause we've understood. Now, so inadequate breastfeeding will cause dehydration, right? And dehydration, weight loss, right? All of these things, they can cause jaundice. Okay. What will be the treatment of this? Continue breastfeeding, ensure proper attachment, proper positioning, and that the nipples are not inverted, right? And ensure frequency of breastfeeding should be every 2 hours. Every 2 hours, you have to ensure that the feeding is taking place. That is about breastfeeding jaundice. So this, the weight loss will be there. And what type of jaundice it will be? It will be unconjugated hyperbilirubinemia. So it will be unconjugated hyperbilirubinemia. And what do you have to do? You have to focus on the technique, positioning, attachment, frequency. Okay, frequency, all this. Okay. And if you think that the milk output is actually low for the mother, then you can give some supplemental feeds. But usually breastfeeding only recovers the neonate completely. Okay, so that is about breastfeeding jaundice. If I have to tell you in one line what is breast milk jaundice, then here in guide is written that the cause is unknown. Okay, but if you search in research papers, they say that there is an enzyme which is beta glucuronidase. Okay, beta glucuronidase. This is an enzyme, or this is a substance which is present in the breast milk, and this interferes with the conjugation of bilirubin. So this substance which is present in the breast milk, beta glucuronidase, this interferes with the conjugation and the enterohepatic circulation of bilirubin, and thus it increases the unconjugated part of bilirubin, causing unconjugated hyperbilirubinemia. Okay, so that is breast milk jaundice. So there is a substance which is present in the breast milk which is causing breast milk jaundice. Okay, what is the substance? Beta glucuronidase substance which is interfering with the conjugation or enterohepatic circulation. Okay. Here, the baby will be breastfeeding adequately. The weight loss will usually not be there. Do you have to stop the mother from breastfeeding? No. You have to continue breastfeeding. Even in this case, it will resolve usually. Okay, it will resolve usually. You have to continue breastfeeding. If it is crossing the phototherapy threshold, you can consider phototherapy, but usually you have to continue breastfeeding. If it is crossing the phototherapy threshold, then you can consider phototherapy. Okay, that's it. About breastfeeding and breast milk jaundice. Okay. So usually breastfeeding jaundice will improve quickly on adequate breastfeeding, but breast milk jaundice usually takes some time to resolve. Okay, so this will improve within a few days of adequate intake, but this may persist for several weeks and it gradually takes time to resolve. Okay, both of them will be unconjugated hyperbilirubinemia. Breastfeeding jaundice is also unconjugated. Breast milk jaundice is also unconjugated hyperbilirubinemia. Okay, so far it's clear, right? Now let's talk about how will you grade the jaundice, or how will you see the severity of jaundice. Okay, so that is by Kramer's zone. This is also known as Kramer's rule. This is also known as Kramer's rule. Okay, so we divide the baby into 5 zones, or 5 zones. The head and neck part is called as zone 1. The chest and the middle abdomen part is called as zone 2. The upper thighs part and the lower abdomen part is called as zone 3. The legs are called as zone 4, along with the arms, and palms and soles are referred to as zone 5. Palms and soles are zone 5. Okay. So zone 1 is 4 to 6 milligram per deciliter. This is zone 2 is 6 to 8 milligram per deciliter. 3 is 8 to 12 milligram per deciliter. 4 is 12 to 15 milligram per deciliter. And 5 is more than 15. So palms and soles, if yellowish staining of palms and soles are seen, that means the bilirubin level is more than 15 milligram per deciliter, and that is a danger sign. Okay. So again, I'll repeat, zone 1 is 4 to 6 milligram per deciliter. Zone 2 is 6 to 8 milligram per deciliter. Zone 3 is 8 to 12 milligram per deciliter. Zone 4 is 12 to 15. So zone 4 includes these legs also and these arms also. Okay. Legs and arms, that is zone 4. And palms and soles is more than 15 milligram per deciliter. Okay, so Kramer's zone or Kramer's rule, this is asked separately also. This is very important. And if they ask you about the algorithmic approach to jaundice, so this is the first thing that you have to do. Okay, so you have to see whether the baby is conscious and all, conscious, alert, not lethargic. Then after that, you will check the severity of jaundice by visual assessment. And this is done by visual assessment. You will apply the Cramer's rule and you will see whether the jaundice is very severe, that is, it is staining the palms and soles or not. Okay. So that's about Cramer's zone or Cramer's rule. Now, what are the investigations that you have to do? You have to check the total serum bilirubin level. You have to check the direct serum bilirubin. Why do we have to check direct serum bilirubin? We have to see whether it is conjugated or not, right? Direct bilirubin, if it is increased, that means it is conjugated hyperbilirubinemia. You have to see the blood group. Why? For Rh incompatibility, which we'll study. Okay, so blood group is A positive. Whether the baby is positive and the mother is negative, then you have to see for Rh incompatibility. So you have to check the blood group. You have to do a direct Coombs test. This is again done in cases of Rh incompatibility. Then you do a CBC with peripheral smear. In peripheral smear, you can see for hemolysis. Okay, and CBC, you can check for the hemoglobin level of the baby, whether the baby is having anemia or not, hemolytic anemia, you can get to know with this. Retic count also for hemolytic anemias, right? And what is the hemolysis? If it is more than 1%, then that indicates hemolysis, right? G6PD is another cause for hemolytic anemias. Sepsis screen, right? Sepsis also causes hyperbilirubinemia. So we have to see that. Thyroid function test. Hypothyroidism is also a cause of prolonged yellowish discoloration, and that also causes jaundice. So you have to rule out hypothyroidism. Therefore, we always do a TFT or thyroid function test in case of hyperbilirubinemia in case of jaundice. So this is very important. Thyroid function test is very important. You have to check for hypothyroidism in neonates with jaundice. Okay. And you can do genetic studies for all the various syndromes that we talked about: Crigler-Najjar, Dubin-Johnson, Rota, right? Gilbert. ABO incompatibility. This is most common immune hemolytic jaundice. Okay. So what happens in ABO incompatibility? Mother has blood group O. Okay. And the baby has A or. So blood group O is universal donor, O negative. Why? Because it lacks both antigens, right? A and B. But blood group O has both antibodies, that is anti-A antibodies and anti-B antibodies. So it lacks both antigens, but it has both antibodies, anti-A antibody also and anti-B antibody also. Okay. Don't know if my handwriting is clear or not. Wait. I'll write again. Anti-A antibody and anti-B antibody. So these are the two antibodies which are present in blood group O. It lacks both antigens, but both antibodies are present, right? Now, when these antibodies are present, and suppose the baby has blood group A, suppose baby has blood group A, okay? Blood group is suppose A. Now, this anti-A antibody will go and attack this A antigen, okay? And now what will happen is there will be hemolysis, right? So if it attacks the antigen, then there will be hemolysis, and that can cause ABO incompatibility and hemolytic jaundice. Okay, so because blood group O lacks both antigens, it has both antibodies, anti-A and anti-B antibodies. So if the baby has blood group A or B because of the father, then what will happen? There can be ABO incompatibility, right? But usually and always this does not happen because mostly the antibodies which are produced are IgM. Okay, so majority of the times does not happen. Then it comes the case of Rh incompatibility. Okay. Now in Rh incompatibility, what happens is if there is a Rh negative mother, first the mother has to be Rh negative. That means the mother lacks D antigen. Okay. So what is the antigen? The antigen is D. So if there is no D antigen, then we label the blood group as Rh negative. If the blood group, if the D antigen is present, then we label it as Rh positive. So this Rh positive fetus, this has D antigen, but the mother is lacking D antigen. Okay. Now first pregnancy happens. First pregnancy में the mother is negative, the baby is positive. The first pregnancy में after the baby is delivered, okay, there is breach of the feto-placental barrier and the maternal barrier, and there will be exchange of the blood. And this phase is known as sensitization phase. This phase is known as sensitization phase, where the maternal blood which is RH negative will encounter D antigen. ठीक है, अब maternal blood को दिख गया D antigen. D antigen will be seen as foreign antigen. ठीक है, maternal blood के अंदर क्या दिखा? D antigen. Mother will recognize this as foreign, something foreign. So mother will start producing what? Anti-D antibodies. So mother will start producing anti-D antibodies. Mind you that this anti-D antibodies are being formed after the first pregnancy, or it can be abortion, or it can be some ectopic pregnancy or something, but something is there, right? So it can be pregnancy, it can be abortion, it can be ectopic in an RH negative pregnancy. Any of these things is there. That is known as the sensitization phase. After this phase, there is the mother blood encounters D antigen, recognizes it as foreign antigen, and whenever our body will recognize something as foreign, we will try to attack it. So mother will start producing anti-D antibodies. Now these anti-D antibodies which are produced, these are of IgG type. If they are of IgG type, they can cross the barrier and they can attack the fetus. So now what happens is there is second pregnancy. And in second pregnancy, this baby is RH positive. Mother is RH negative, baby is RH positive. This baby is having D antigen. In second pregnancy, this baby is having D antigen. Mother has anti-D antibodies which will attack the D antigen of the fetus, and there will be hemolysis. So this is the pathogenesis of hemolytic disease of newborn or RH incompatibility, which has been asked. So first pregnancy, sensitization phase. Then in second pregnancy, what will happen is because of, then after the sensitization phase, production of anti-D antibodies, and these anti-D antibodies will attack the baby in the second pregnancy if the baby is also RH positive and the mother is RH negative. Okay. So this we'll just see. So father is RH positive, only then the baby can be, right? Mother is RH negative, baby, father is RH positive, and the first RH positive pregnancy is the sensitization phase. So first RH positive pregnancy is the sensitization phase. Okay. Then in the interval period, what will happen? There will be production of anti-D antibodies. So there's production of anti-D antibodies, right? There are anti-D antibodies which are produced, right? These are anti-D antibodies which are produced. And in the subsequent RH positive pregnancy, that is the second pregnancy, what will happen? There will be anti-D antibodies, they will start attacking the fetus. So now these anti-D antibodies, you see these antibodies, they're attacking the fetus. So now what will happen in this baby? There can be hemolytic anemia. Right? There can be hemolytic anemia, there can be hyperbilirubinemia, there can be jaundice, there can be hydrops fetalis, okay? And there can be intrauterine death, even there can be kernicterus in several severe cases. So hemolytic anemia, hyperbilirubinemia, jaundice, so this can happen, okay? So this I think we've studied first pregnancy sensitization and subsequent RH positive pregnancy. Okay. No effect on first baby is important. Okay, so there is no effect on the first baby. So the first baby, there will be no effect. Okay. So on first pregnancy, there is no effect on the first baby. Okay, only on the subsequent pregnancy, there will be effect. And what is the prevention of this? What is the prevention? Anti-D immunoglobulin. Okay, so we have to administer anti-D immunoglobulin to the mother, right? That is the at 28 weeks of pregnancy and 72 hours after the delivery. You have to give anti-D immunoglobulin to the mother for prevention of RH incompatibility. Okay. So clinical features can be jaundice, anemia, hydrops fetalis, kernicterus. Now let's come to management of neonatal jaundice. So management of neonatal jaundice matlab pehle you have to write about investigations and then you will come to the treatment part. Investigations we've already discussed. Before investigations also you should write about the visual assessment, right? And then you will write about investigations which we discussed. What were they? total serum bilirubin, direct serum bilirubin, blood group, Coombs test, thyroid function test, right? G6PD screen, retic count. So all these things you have to do. Then management of neonatal jaundice. Treatment will be, first you have to ensure adequate feeding. You have to ensure proper attachment, proper positioning, right? And increase the frequency of feeding every 2 hourly. Every 2 hourly, the mother has to breastfeed the baby. Okay. Second is phototherapy. Phototherapy will be just seeing what is it, right? Phototherapy. Then you can give IVIG. This is given in cases of RH incompatibility. Okay. In cases of RH incompatibility, what we can give is, and even ABO incompatibility, we give IVIG. Okay. So specifically for RH incompatibility, if a question comes, you should talk about continue breastfeeding, phototherapy, IVIG, and in severe cases, you can go for exchange transfusion. In severe cases, you can go for exchange transfusion. Okay. Now, what is the follow-up in these babies with severe neonatal jaundice? You should always follow up with BERA. Okay. You should always follow up these neonates with BERA in cases of severe hyperbilirubinemia to look for hearing loss. Okay. To look for hearing loss, all cases of neonatal jaundice should undergo BERA. Okay. Now, what is the principle of phototherapy? So, what light do we use? We are usually using LEDs now, especially in the tertiary care hospitals. We are using LED lights. Okay, CFL lights are also used in primary setups, right? PHC setups and all. We're using CFLs, but usually big hospitals have switched to LEDs. Okay. We are preferring LED lights now because one, they're more safe, they have longer lifespan. Okay, and they are also considered to be superior and more effective in cases of neonatal jaundice. Okay, so CFL and LED lights we are using. And what is the spectrum of light? We use blue-green light and the range is 460 to 490 nanometers. Okay, so this is the wavelength, 460 to 490 nanometers, blue-green light has to be used. What is the principle? We want to convert the insoluble part of bilirubin into water-soluble products such that it can be excreted out. Okay, so insoluble has to be converted to water soluble such that it can be excreted out. So there are 3 ways. Now these 3 steps they're given in GHI, and this you should remember because it's given in a standard book, right? They expect that you should remember. So one is configurational isomerization. Here they convert Z isomers to E isomers, and this step is reversible. Okay, so configurational isomerization is, this is just conversion of one form to another, Z to E form, and this step is reversible. This step is reversible. If you talk about structural isomerization, here this is the irreversible step, and this is also the key step in phototherapy where bilirubin is being converted to lumirubin. So bilirubin is converted to lumirubin, and this is the irreversible step, and this is the most important step which takes place in phototherapy. And this lumirubin is the water soluble form, so this can be excreted out, right? Now this photooxidation takes place, and these photoproducts can be excreted in urine. Okay, so configurational isomerization, structural isomerization, and photooxidation. These are the 3 steps in phototherapy. Not much to understand. Basically, you have to remember these 3 things that are given. So this is a baby which is receiving phototherapy. If you see closely, then you will see that the eyes are covered and the genital areas are also covered. Why is that? Because phototherapy is toxic to eyes. It can cause retinal damage and also the genital part. So you always cover the eyes and the genital part. Okay. So let's see the complications of phototherapy. One, the first very important thing is dehydration and weight loss. Okay, so the babies receiving phototherapy, if there's a lot of light, right? So that can cause dehydration, that can cause weight loss, and therefore adequate breastfeeding during phototherapy. Adequate feeding during phototherapy is very, very important. So first is dehydration and weight loss. Second is loose stools. Loose green colored stools are usually seen in cases of phototherapy. Other is bronze baby syndrome. This happens if a baby with conjugated hyperbilirubinemia. If a baby with conjugated bilirubin undergoes hyperbilirubinemia, undergoes phototherapy, then what happens is bronze baby syndrome. Then I already talked to you about eye injury or retinal damage, right? Phototherapy can cause. Therefore, you cover the eyes, and also it can, affect the genital area also. So you cover that also. Then there can be some rash, right? Dermatitis can happen. Some rash can happen, right? Because of phototherapy. and electrolyte disturbances. Because of dehydration, weight loss, there can be some electrolyte disturbances, hypocalcemia particularly, so that you have to take care of. Okay. Now, what are the indications of phototherapy? If you talk about the indications of phototherapy, basically there's a graph which we follow, that is Botany nomogram. Okay. So you see this Botany nomogram. I'll just write the spelling again. I think it's not clear. I'll write it in capital. Botany nomogram. Basically, it's like a graph. Okay. Here they are given values of bilirubin. Okay. And lines like these are there. Okay. And you plot the level on these graphs. Okay. So if it is crossing this line, then you have to give phototherapy. Okay. So you have to plot it on the chart. So basically gestational age is given and gestational age and bilirubin levels. So based on gestational age, what should be the bilirubin level is given on this graph. And then you will just check corresponding to the gestational age. If the bilirubin level exceeds the phototherapy limit, then you will give phototherapy. If it exceeds the exchange transfusion limit, then you will go for exchange transfusion. Okay. So that is based on Botany nomogram. And also if there is severe jaundice, if there are convulsions, if there is kernicterus, if it is staining the palms and soles, all of these are indications of phototherapy, right? Indications of exchange transfusion. Convulsions are happening in a baby, kernicterus is there, right? Severe RH incompatibility is there. All of these are also indications of exchange transfusion, and there is failure of intensive phototherapy, right? Phototherapy fails, that is also an indication of exchange transfusion. Okay, in cases of RH incompatibility, what is the indication for exchange transfusion? This is also given in Ghai, okay? If the cord bilirubin is more than 5 and if cord hemoglobin is less than 10, then this is an indication for double volume exchange transfusion in cases of RH incompatibility. Okay, cord bilirubin more than 5, cord bilirubin more than 5, and cord hemoglobin less than 10 gram per deciliter. Okay, so cord bilirubin more than 5 milligram per deciliter, but cord hemoglobin more than less than 10 gram per deciliter. Okay, so this is indication for double volume exchange transfusion in case of RH incompatibility. Okay. Now, what is the procedure? I think there's one image which explains it well. Okay. So here you see this baby, there is a umbilical venous catheter. So there's an umbilical venous catheter, and to this catheter, we attach a 3-way stopcock. Okay. And here what we will do is we'll take one blood bag from the blood bank, and that blood will be matched, cross-matching, and everything will be done as per the blood group of the baby, but it will be fresh blood. Okay. And we will withdraw the blood of the baby, right? We will pull the baby's blood, and we will push the blood that we've got from blood bank into the baby, right? So we will pull and we will push. So push and pull technique of double volume exchange transfusion. So undesired blood, that is the baby's blood, which is having problem. Okay, it can be RH incompatibility, it can be some other thing. The bilirubin levels are very, very high. So we want to take out the blood and we want to exchange the blood with another blood which has normal bilirubin levels, right? So the technique which is followed is known as push and pull technique. Push and pull technique, right? Push the desired blood and withdraw the baby's blood, right? Push and pull technique, right? So withdrawal, so we will attach 2 blood bags are there basically. So one blood bag is, and usually take it in form of small aliquots, okay? 20 ml or around 10 ml, depending upon the weight of the baby, okay? And UVC tip should reach ideally up to IVC. So what is the volume? It is usually 160 to 180 ml per kg, okay? That is about double volume exchange transfusion. So umbilical venous catheter, this takes place through umbilicus venous catheter. What is the technique? Push and pull technique, right? And you have to do continuous monitoring. Here you have to attach a ECG monitor when you are doing exchange transfusion to the baby. Okay, ECG monitor, SpO2 monitoring, all these monitoring have to take place along with double volume exchange transfusion. Okay, so this we have seen. Complications, I think complications here only will do. Okay. So complications can be bradycardia, they can be apnea, there can be electrolyte imbalances, right? There can be, see this, complications of exchange transfusion can be bradycardia, there can be apnea, there can be electrolyte imbalances like hypocalcemia and hyperkalemia, okay? And there can be catheter related complications also, because you're inserting a umbilical venous catheter, which is going up to the level of heart almost, right? You have to, after you attach this UVC, you have to do a X-ray and you have to see where is the tip of the UVC, and only then you start this double volume exchange transfusion, right? So there can be catheter related complications, malposition. It is entering into the heart. Okay, it's causing some arrhythmias. Okay, and there can be bleeding in the catheter. Now, whenever you're inserting a foreign body inside, there can be infections, right? When you insert a urinary catheter, there are UTIs. So here also there can be infections, and it can also cause NEC, which is necrotizing enterocolitis of the colon. Okay, so there can be malpositioning, there can be arrhythmias, there can be bleeding, there can be infections. These are easy things. There can be bradycardia. There could be apnea also. Okay, and electrolyte imbalance like hypocalcemia, hypocalcemia, and hyperkalemia. Okay, so monitoring, continuous cardiac monitoring. I talked to you about ECG, right? SpO2, BP, heart rate, and you should also look for serum glucose. Okay, blood glucose level should also be checked, and electrolyte levels. Okay, so proper sterile technique is followed, and what is the double volume exchange transfusion? How much volume of blood? That I told you, right? 160 to 180 ml. That is 2 into baby's volume. That is usually 80 ml per kg. So 2 into 80 is 160. Okay. Per kg, ml per kg. 80 ml per kg. So 2 into 80 is 160 ml per kg. And you have to use warm blood. Okay. So after you get it from the blood bank, you have to warm the blood and then you have to use it. Okay. Next, let's see what is the pathway of bilirubin toxicity. Now, if bilirubin is depositing in the skin and mucous membranes, it will cause jaundice. This is easy. If this unconjugated bilirubin, we talked about unconjugated bilirubin being fat soluble. If it is fat soluble, it can cross membranes. So this unconjugated bilirubin being fat soluble, this we talked about, can cross blood-brain barrier, and this can cause deposits in the brain and cause acute bilirubin encephalopathy, right? Unconjugated bilirubin causing acute bilirubin encephalopathy, crossing the blood-brain barrier and causing acute bilirubin encephalopathy. Okay, causing some neurological signs. This will study. And if there is permanent damage, so on this acute bilirubin encephalopathy is reversible, right? You give phototherapy, you give exchange transfusion, you give treat the underlying cause. This is a reversible condition. But if there is permanent neuronal damage, like there is kernicterus, permanent neuronal damage is kernicterus, then this is a irreversible thing. Okay, this is a permanent damage and this is irreversible. Okay, and this usually affects the basal ganglia. Also affects the auditory pathways. Therefore, we said that in all cases of neonatal jaundice should be followed up with BERA, right? You have to do a hearing assessment in all cases of neonatal jaundice. So, kernicterus is basically the chronic neurological sequelae which happen in a baby with neonatal jaundice, right? So, acute bilirubin encephalopathy, there are 3 stages. So, early stage, intermediate stage, and advanced stage. In early stage, the baby will have poor feeding. Okay, the baby is poor feeding, will have hypotonia. Okay, so muscle tone will be decreased. Initially, the muscle tone is decreased, but if you go to the advanced stage, the tone is increased. The posturing will be opisthotonous, like the baby will be arching the body, right? So the tone is greatly increased. So we have to see tone. One thing is tone, and tone is decreased initially, but in advanced stage, it is opisthotonous. There is hypertonia. It is greatly increased. Okay, here also in intermediate stage also the tone is increased. So initially the tone is decreased, but it increases in the intermediate stage and increases greatly in the advanced stage. Okay. Poor feeding, lethargy, hypotonia, right? Weak cry. That is early stage. Intermediate stage, there will be high pitched cry. So you have to see the tone, you have to see the cry. Okay. To see cry. Here, again, inconsolable cries. Then advanced stage also there's inconsolable cry. One, there can be inconsolable cry. The second thing is there can be coma also. Okay, the baby is having coma or the baby is extremely lethargic, but the baby is having very high tone. Think of acute bilirubin encephalopathy. Okay, the baby can be having seizures. Here also the baby can be having seizures. Here also advanced stage. Okay, so what are the basically, if I talk about the features, if you don't have to write in stages and you have to write overall, then you should write tone is increased. Right, the tone is increased. You can write initially it is decreased, but usually the classical feature is that the tone is increased. There is opisthotonus, there is inconsolable cry. In later stages there can be coma. Okay, in later stages there can be coma. So you have to talk about the tone, you have to talk about the cry, and you have to talk about how the baby is, the overall well-being, whether the baby is lethargic, whether the baby is irritable, whether the baby is completely comatose. Okay. So usually the basal ganglia is affected, right? Usually the basal, here also basal ganglia is affected usually because bilirubin goes and deposits an affinity towards the basal ganglia. It has an affinity towards the gray matter and particularly the basal ganglia. Okay. So this is the cry pattern, the tone, and the mental status. So these three things you have to see: the muscle tone, the cry, and the behavior. Okay. So tone can be variable. Here, hypertonia. Here, severe hypertonia is there usually. Okay. Opisthotonus hypertonia. Now let's see. So this is about bilirubin encephalopathy, acute bilirubin encephalopathy. This is seen. This is because of acute neurotoxicity. Okay, acute neurotoxicity. Here, kernicterus is chronic and it is permanent damage. Here it is chronic and there is permanent damage. Okay. So bilirubin will go and deposit in the basal ganglia, in the brainstem nuclei, and there will be permanent brain damage. There will be permanent brain damage. What are the risk factors of kernicterus or bilirubin encephalopathy if they ask you? Okay, same risk factors will be there. Prematurity, if they ask you what are the predisposing factors for bilirubin encephalopathy, what are the predisposing factors for kernicterus, you have to answer the same things. Okay, prematurity, RH incompatibility, cephalhematoma, these things you already know. Sepsis, you know, right? Extra things that you have to remember is acidosis, hypoxia, right? Acidosis, hypoxia, hypoalbuminemia. Why hypoalbuminemia? Because the unbound form of bilirubin will increase here, right? Albumin binds the bilirubin, but if there is hypoalbuminemia, the bilirubin will exist in unbound form. So prematurity, RH incompatibility, cephalhematoma, sepsis, acidosis, hypoxia, hypoalbuminemia, these all are predisposing conditions for kernicterus. Okay. Now what is the pathophysiology? So there is severe jaundice because of increased production of bilirubin or there is impaired excretion of bilirubin. Either there is increased production or there is impaired excretion. So because of that, any of the causes that we studied, there is increased unconjugated bilirubin. And increased unconjugated bilirubin will cross the blood-brain barrier because it is fat soluble and it will go and deposit in the brain tissue, in the basal ganglia, globus pallidus, subthalamic nuclei, and it will cause neuronal toxicity. Okay, so there can be mitochondrial dysfunction, there can be oxidative stress causing neuronal injury and apoptosis. And this neuronal injury is of permanent type, right? So there can be mitochondrial dysfunction, there can be neuronal toxicity because of the bilirubin which is going and depositing there, right? Which can cause acute bilirubin encephalopathy initially, but later on what can happen is there can be permanent brain damage. Okay, so later on what can happen is there can be permanent brain damage. Okay. Now we'll just see what are the main features here. So one is chorioethetoid cerebral palsy. Ethetoid cerebral palsy. Okay, chorioethetoid or ethetoid cerebral palsy. You know that when the basal ganglia is affected, right? Basal ganglia is responsible for all the involuntary movements of our body. Chorea, ethetosis. You've talked about Huntington's chorea in medicine. That is caused because of a lesion in basal ganglia, right? So here, ethetoid cerebral palsy will happen. Ethetosis is an involuntary movement. When basal ganglia is affected, there will be ethetoid cerebral palsy. Okay. Sensory neural hearing loss, because it also affects the auditory pathway. There will be gaze abnormalities. Upward gaze abnormalities are usually there. Dental enamel dysplasia and intellectual disability. These 5 features you have to remember by heart. That is, देखो आँख, कान, दांत, brain, right? All these things are problem, right? So brain में ethetoid cerebral palsy, आंखों में upward gaze palsy or gaze paralysis, sensory neural hearing loss, right? कान में sensory neural hearing loss, dental enamel dysplasia, and along with that there is intellectual disability, right? So chorioethetoid cerebral palsy, upward gaze paralysis, sensory neural hearing loss, dental dysplasia, and intellectual disability. Done. Management. So management of kernicterus, treat the underlying cause. Now, in many cases that they've given is that they have shown that the baby is having seizures. If the baby is having seizures, first of all, give a anti-epileptic. Okay, so in neonates, we use IV phenobarbital. So airway, breathing, circulation. Whenever you see a complicated case or an emergency case, you should always start with ABC, right? Whether it is medicine, whether it is peds, whether it is surgery, whether it's obsgyne, start with ABC, airway, breathing, circulation, establish IV access, take blood for investigations, and then you start with, okay, now what is the first thing that you have to do? Now, you will give, if the baby is having seizures, so first priority has to be treating them, IV phenobarbital. Okay. Then you come to other things. Treat the underlying cause. Also, in a baby with seizures, you have to give oxygen also. Okay, so you have to give oxygen, you have to give IV phenobarbital. Okay, and then you have to treat the underlying cause. Give phototherapy, give exchange transfusion. This will come later. Okay. So intensive phototherapy, exchange transfusion, IVIG, injection phenobarbital, right? So in all cases of seizures, you have to give injection phenobarbital. IVIG will be given in cases of RH incompatibility, right? And this you will decide based on Botany nomogram, right? This you will based on gestational age related cutoffs. कितना cutoff है उसका जरूरी है कि नहीं देना? So gestational age related cutoffs, which you will see on plotting on graphs, right? And then accordingly you will give phototherapy or exchange transfusion if it is needed. Hearing rehabilitation, physiotherapy, and speech therapy, right? If you write these things, you get extra marks, right? Hearing rehabilitation, physiotherapy, speech therapy, right? This is important. So now we come to the end, right? Let's again see the previous year questions which have come. So causes of unconjugated hyperbilirubinemia, we have done. Mechanism of action of phototherapy, conversion of insoluble to water soluble fractions, those 3 steps which we studied, right? Configurational, structural, and photooxidation. Potential complications of phototherapy, we've discussed. Physiological jaundice of newborn, we've seen. What are the predisposing causes, we've seen. Now read this question. A term neonate born to a O negative blood group mother, means the mother is Rh negative, is found to have deep jaundice involving palms and soles. So the baby is having deep jaundice. Okay, so this is a case of Rh incompatibility. Jaundice है, Rh negative mother है, Rh incompatibility है, and palms and soles में है, मतलब more than 15 milligram per deciliter है, मतलब severe वाला jaundice is there, right? And the baby is having excessive crying and convulsions also, मतलब baby is having bilirubin encephalopathy. Okay, at 20 hours of life. So how will you assess the clinical severity of jaundice in this neonate? So first clinical severity के लिए आपको क्या लिखना है? Cramer's zone, right? So how will you assess the clinical severity of jaundice? Cramer's zone. And also what you can do in this neonate is acute bilirubin encephalopathy के लिए score होता है. तो ABE scoring. Okay. So if you write this very few people are going to write acute bilirubin encephalopathy scoring. Okay. So if the bilirubin ABE score is more than 7, that means it is severe. So jaundice की severity के लिए बट उन्होंने specifically jaundice की severity पूछा है, तो severity of jaundice कैसे देखते हैं वो Cramer's zone से देखेंगे. But अगर इसमें तुम्हें bilirubin encephalopathy also if you want to write, then that will be ABE scoring. List the investigations to arrive at the diagnosis. So here what you will do? You will do total serum bilirubin, you will do direct serum bilirubin, you will do a Coombs test, right? You will do a DCT, direct Coombs test. You will see the hemoglobin level also if there is anemia, because here anemia also happens. There is hemolytic anemia, right? So hemoglobin level also you have to do. What else? Obviously baby's blood group likha nahi hai yahan pe, so you should do a baby's blood group test also. Now this is one part. The other thing is the baby is having convulsions also, so you should do a EEG. If the baby is having convulsions, you also have to do a EEG. So investigations are done. Management हमने अभी discuss किया what you will give, right? Causes of neonatal jaundice, we've seen. Algorithmic for workup, you can write, right? So how will you manage a 34-week newborn at 7 days of life having 1.6 kg of weight? Matlab, baby is underweight, right? Low birth weight. Less than 2.5 kg means the baby is low birth weight and the baby is preterm also. 34 weeks. Preterm baby hai. 7 days of life पे 1.6 kg weight है. Hyperbilirubinemia है. Okay. So, इसमें क्या management होगा? What will be the management over here? You can write what will be the management. Breastfeeding करेंगे, right? And you will assess the severity then. Now you have to assess the severity of jaundice. Is hyperbilirubinemia because of prematurity alone? Is it physiological jaundice? Is it pathological jaundice? So first of all, you have to see whether it is physiological, whether it is pathological. If it is physiological, continue breastfeeding and then you have to wait and watch, right? If it is pathological jaundice, then you have to see what is the underlying cause. You will list all the investigations, right? What will be your algorithm? First, see whether it is physiological, whether it is pathological. If it is physiological, continue breastfeeding. If it is pathological, do all the investigations, which we talked about, and then reach to the cause. Now you will give phototherapy based on the cutoff, gestational age cutoff, and if required, you can give exchange transfusion also. So that will be your management. Okay. Enumerate the indications of exchange transfusion and outline the procedure. So indications of exchange transfusion, you know. What are the indications? Severe hyperbilirubinemia, acute bilirubin encephalopathy, right? And RH incompatibility, severe, right? All these are indications. And then we studied in cases of RH incompatibility, if the cord bilirubin is more than 5 or if cord hemoglobin is less than 10, then you will go for exchange transfusion. So this is written in guide, so you should write this and outline the procedure. Procedure we have seen, push-pull technique through umbilical venous catheter, insert it, do an X-ray, check where is the tip, withdraw aliquots, and what is the volume that you withdraw, or the exchange transfusion is done for how much volume? 160 ml per kg. So 2 into blood volume of baby, that is 80 ml per kg. 2 into 80 is 160. So 160 ml per kg. Here the weight is given, right? 1.6. So you will multiply. Okay. 160 into 1.6. Describe the clinical features of bilirubin encephalopathy in early neonatal period. This we talked about. You can write this. The predisposing factors we have seen. Pathological sequelae of bilirubin encephalopathy means kernicterus. So 5 things: chorioathetoid cerebral palsy, sensorineural hearing loss, right? You've seen this. Dental enamel dysplasia, upward gaze palsy, and intellectual disability, right? Can't knock that, so you can write that. Term neonate born to RH negative. This again is RH incompatibility, so you can write this. And prevention, we studied what is the prevention? Anti-D immunoglobulin, right? Anti-D immunoglobulins, which is given at 28 weeks and 72 hours after the birth. Okay, so after first pregnancy also, just after sensitization phase, you should give anti-D immunoglobulin. Okay. Kernicterus, we've seen. How will you prevent kernicterus? This also. How will you prevent kernicterus? Treat the underlying cause, ensure adequate breastfeeding, right? Phototherapy, early phototherapy, right? Before it reaches the cutoff. So this. Enumerate the clinical factors. This we've seen. So I think we've covered all questions and that is all from my side. Hope you enjoyed this lecture. Follow UPSC RX for more such videos. Thank you.